Ma'am, we are on live.
Okay, let's start. Thank you.
Respected Chairperson, keynote speaker, honorable panelists, Assalamu alaikum. This is Dr. Sharmeen Abbasi, Academic Associate of Planetary Health Academia. Welcome you all in today's very important scientific session. Today, we will talk of a very important topic, that is hypertensive disorder in pregnancy. Because hypertensive disorder in pregnancy, the obstetrician needs to manage this sort of cases in everyday and day-to-day practice. So we are very much privileged that for this session, we get as a chairperson to Dignified from Bangladesh and India. And as advisor, Professor Tasbirul Islam will join with us shortly. And as a keynote speaker and panelist, we have a very prominent and very experienced panel group to talk regarding this topic. And as a faculty lead, we have Dr. Rehana Zaman with us. She's working as a consultant of obstetrics and gynecology in Nobles Hospital. So I want to say that with me, the co-moderator is Dr. Joyashree Shah. Dr. Joyashree Shah currently working as Associate Professor of Obstetrics and Gynecology in Popular Medical College Hospital. As advisor, we have Chairman of Planetary Health Academia, Dr. Tasbir. He is a clinical associate professor and board certified in internal medicine, pulmonary and critical care. And as a chairperson of this session, we have Professor Farhana Dewan. Professor Farhana Dewan is a name of a proud chapter of Bangladesh. She is now the president of Obstetrical and Gynecological Society of Bangladesh, Deputy Secretary General of SAFO, Professor Department of OBGYN Ibn Sina Medical College Hospital, Deputy National Coordinator, FIGO LDI Project BD, FIGO PPH Bundle Project, and FIGO PP IOD Project. And one of the important position is Secretary General of Bangladesh Chapter of Organization of Justices. So Madam can give idea and say about some aspects of justices related with the hypertensive disorder in pregnancy. And she is also the organizing secretary of Endometriosis Adenomyosis Society of Bangladesh, ex-professor, Department of OBGYN in different medical college, and extensive academic working experience in different government medical college of Bangladesh. Please welcome Madam as the chairperson of today's session. And we have another chairperson, and we are very much delighted to get Dr. Lashmi, Madam, Dr. Lashmi Shrikande. She is the chairperson of ICOG, Indian College of OBGYN, National Corresponding Editor, Journal of OBGYN of India, National Corresponding Secretary, Association of Medical Women India, Founder Patron and President ICOPRAB, Chairperson IMS Education Committee, President Association of Medical Women Nagpur, Nagpur Ratan Award, received Bharat Excellence Award of Women's Health. Is excellent, Madam. To get you among us, Madam have a chairperson position of HIV/AIDS Committee of the FOXI, and also receive an appreciation letter from Maharashtra government for her, and work in the field of Save the Girl Child, Senior Vice President FOXI 2012, President Menopause Society Nagpur, and President Nagpur OBGYN Society 2005 to 2006, delivered 11 oration and 450 guest lecture. There are many publications, many awards for Madam. So Madam, we are very much privileged and proud feeling that you are joined with us. Thank you for joining us.
Thank you, Sharmeen.
Yes, I think Tasbir sir not with us at this moment. So I'm requesting the chairperson of PHA OBGYN Bangladesh chapter, Professor Roshonara Begum, to give the welcome address. Professor Roshonara, Madam, please.
Thank you, Professor Sharmeen, Dr. Sharmeen, for your excellent introductory lecture. Actually, Planetary Health Academy, we are running for a few days, not, I think already 2 years, yeah, Sharmeen?
Yes,
more than,
yes.
More than 2 years. So we want to collaborate also with our Indian faculties. We want to exchange our views, because hypertensive disorder in pregnancy is a very common complication in our both in this subcontinent And it is for this complication, eclampsia is one of the major cause of maternal death in our country, and also I think in our subcontinent. And it is the only case we can prevent it. So we have to be upgraded with this subject. So I'm welcoming everybody. We know already Sharmin described everything about you all. So I am welcoming everybody, and I want to start the session. Thank you.
Thank you, Professor Roshanara, Madam, the Honorable Chairman of the OBGYN Bangladesh chapter of Planetary Health Academia. We have a very expert panelist group, and the panelist group introduction will be done by our another moderator, Dr. Jayashree Shah, regarding the panel discussion session. So we are switch over to our most important part, the keynote lecture part. The keynote lecture on hypertensive disorder in pregnancy. And our keynote speaker is Professor Zinatara Nasrin. Professor Zinatara Nasrin is the head of the Department of OBGYN of Shohid Shikdar Medical College Hospital and the Secretary General of Bangladesh Menopause Society, Secretary General of PCOS Club of Bangladesh, former Scientific Secretary of Obstetrical and Gynecological Society of Bangladesh, and present Chairman of the CME Subcommittee of OGSP. And Madam is a gold medalist. She has a huge academic experience. She has a huge academic achievement. So please welcome, Madam. Your keynote speaker, I think, will be very valuable for our mid-level and for our junior doctors. And I know in your every lecture, you always give us the recent updates. So it will also update our knowledge also. So please welcome our keynote speaker, Professor Sheikh Zinatara Nasrin. Madam, please. Slide share it with the editor, madam. Just give slide share. Full screen. Yes, thank you. To unmute Corbin, madam. Professor Samina Chaudhary, one of our past president of OBGYN Society, also joined. Thank you. And Dr. Tasbir sir is joined. Tasbir sir is the chairman of the PHJ. Tasbir sir, we can take your comment just after the presentation of Zinat, madam, sir. Because we already start the presentation. Yes,
Absolutely.
Thank you. Thank you. Madam, unmute Corbin, please, yourself. Zinat, madam, unmute yourself.
না আমি পাচ্ছি না খুঁজে
হ্যাঁ ফুল স্ক্রিনটা করো হয়েছিল তো এর আগে
এই যে এখন আমি তো মানে আনমিউটেডই ছিলাম এখন আবার করি আবার শেয়ার করি সরি
We have 82 participants in the Zoom and more than 2,000 in the social media from different countries. Zinat madam is trying, by this time we can hear, yes.
শারমিন দেখা যাচ্ছে
হ্যাঁ ম্যাডাম এবার আপনি full screen দেন
Okay.
Yes,
Perfect. Thank you very much, Dr. Sharmin, for your kind introduction. Well, just before my talk, I'd like to express my deep gratitude and thanks to Planetary Health Academia for giving me the opportunity as a keynote speaker for this very prestigious webinar. Today's advisor and esteemed panelists, beloved delegates and respected participant. Assalamu alaikum and good evening actually from Bangladesh. Anyway, so my talk is today, hypertensive disorder of pregnancy. Well, hypertensive disorder of the pregnancy is actually, they are the multisystemic disorder of pregnancy. Typically it affects 5 to 10% of pregnant women. And this is one of the leading cause of maternal and perinatal morbidities and mortalities in Bangladesh. Unfortunately, globally, 76,000 women and 500,000 babies are dying every year. And if you look at the stillbirth data, 1 in 20 stillbirth without the congenital abnormality attributable to preeclampsia. But there are a lot of challenges of this hypertensive disorder of pregnancy, the challenges in the clinical management, the timed intervention, and fine-tuning of the timing of delivery. So my objective of talk will be on discussion of these challenges of the hypertensive disorder pregnancy, classification, determination a little bit about the blood pressure, preeclampsia, eclampsia, and my main focus will be on preeclampsia. Well, if you go for the classification, actually there are two broad headings. One is the chronic hypertension, another is the pregnancy-induced hypertension. And among the pregnancy-induced hypertension, there's a gestational hypertension, preeclampsia, eclampsia, and chronic hypertension with superimposed preeclampsia and eclampsia. Chronic hypertension, well, the incidence is not less. It's 3 to 5% pregnancy are being affected with this chronic hypertension. Actually, this is defined when the blood pressure is more than 140 to 90 or equal
আমরা কি শুনতে পাচ্ছি ম্যাডাম? কি আমি তো পাচ্ছি না।
না,
আমার
ওদের
মনে-
কোথায় ডিস্টার্ব হচ্ছে
Network-এ-
কোথাও। হ্যাঁ
নেটওয়ার্কের প্রবলেম
Okay.
হচ্ছে সবাইকে। আসসালামু আলাইকুম সবাই।
হ্যাঁ, তাসবিহ ইসলাম, ভালো আছো?
এই তো আপা, আপনার সাথে দেখা করতেই পারলাম না আর।
না, আসতেছি, দেখা হবে।
আচ্ছা আচ্ছা, ইনশাল্লাহ ইনশাল্লাহ। হ্যাঁ, মারুফা বলছে।
I think her screen got frozen, isn't it? Looks like there's internet problem,
So,
maybe.
হ্যাঁ।
নেটওয়ার্ক
আচ্ছা,
নেটওয়ার্কে
জিনাত,
ম্যাডাম আপনি আবার একটু শেয়ার করুন, আমরা আপনাকে হারিয়ে ফেলেছি। জি,
এটি হচ্ছে
I think it's a network problem, I think.
right.
ইনসেপ্টটা একটু দেখো, দেখি।
না, নেটওয়ার্কটা মানে অফ হয়ে গেছিল ম্যাডাম।
আচ্ছা,
মনে-
ঠিক আছে, দেখো।
I'm requesting the participant to put your question regarding the hypertensive disorder in pregnancy, because who will ask the best question, he or she will get one of the very exciting prize from Planetary Health Academia today. So we know we have many questions regarding hypertensive disorder in pregnancy. So you can ask. Yes, madam. You can
Sharmeen?
continue. Yes, you can continue, please.
So I have already told about the chronic hypertension. It's superimposed. So other two are there. That is white coat hypertension. It is very interesting that women, when they're coming to the OPD or antenatal clinic, their blood pressure shoots. And that is, of course, more than 140/90. But while they're at home, their blood pressure is quite normal. That is actually white coat hypertension. And this is not entirely benign, because many of the cases might proceed to preeclampsia. So we need to keep eyes on them. And mask hypertension, just opposite to the white coat hypertension. Here, the patient, when it comes to chamber or OPD or antenatal clinic, their blood pressure is perfectly okay. But while they're at home, their pressure shoots up. So that is the mask hypertension. That mask hypertension is not that significant, but again, we have to keep eyes on them too. Gestational hypertension, that is very important. Actually, when the blood pressure is more than 140/90 or equal to 140/90, which appears after the 20 weeks of gestation in a previously normotensive and non-proteinuric women. And preeclampsia, I'll just talk very soon. Eclampsia is nothing but when preeclampsia is complicated with convulsion or fits. Preeclampsia. Well, that landscape of the preeclampsia is changing over the years. I mean, if you look at the definition, in our time, it was high blood pressure, proteinuria, with or without edema. Now edema is obsolete. It came for last decade that high blood pressure, I mean, more or equal to 140/90 after 20 weeks of pregnancy with proteinuria. So, but recently it is being also changed. What is the new nomenclature? It is seen that the redefinition is new onset of hypertension and new onset of altered angiogenic factors. Just a minute. Can you continue just 1 minute?
Okay, madam. Then we can ask something regarding the classification. Rehana Appa, would you please add here regarding the preeclampsia classification as P without or severe disease? The recent update, is it show anything or is it say anything, Dr. Rehana Zaman? Or in UK protocol, you are classified in the same way or not, Appa?
So with the preeclampsia, the classification, if there is blood pressure more than 140/90, systolics is 140 and diastolics more than 90. But if there is any organ involvement, it can be hepatic, it can be renal. If there is a thrombocytopenia, then we should classify is as a preeclampsia. But there's something recently also been added, that if we actually, you sometimes diagnose the preeclampsia retrospectively, like maybe the lady will present with IUGR and you find that there is placental insufficiency or the placental disease. And so if there is a high blood pressure with the placental disease, that's also been defined as preeclampsia nowadays. So, and I have seen in my clinical practice that sometimes first presentation will be small for date or IUGR, and then subsequently the mom's blood pressure will go up. So we try to keep them, keep an eye on them, especially if they're primigravida. So that's the new classification. Actually, I have got a small, Zinatapa, are you here now?
Yeah, I'm here.
Yes, Zinat Madam here.
So can you take over then?
Okay, thank you for disturbance. Well, it's same. What was Rehana Zaman was speaking. Actually, there is a redefinition, and nowadays this has been, redefined, like new onset hypertension and new onset of altered angiogenic factors. So, what's just now Rehana told, that preeclampsia is now defined, that is, it's gestational hypertension accompanied by proteinuria, or it will be accompanied by one or more new onset organ dysfunction. And what are those organ dysfunction? Let us see. I have already mentioned that when the blood pressure is more than 140 or equal to 140/90 after 20 weeks of gestation with proteinuria. The proteinuria is actually, you can measure that it should be 300 milligram per day, or protein creatinine ratio when it will be more than 3 milligram, and urine dipstick when more than 1, +2. Actually, we are doing this urine dipstick more often. And what are the organ dysfunction? Acute kidney injury, when it will be the creatinine level more than 1.1 milligram. There will be liver involvement, where the liver enzyme are elevated, and 2 times of the upper level, like LTST will be higher than more than 40 international unit. And there could be neurological complications, like eclampsia or blindness, unconscious, stroke, severe headache, persistent visual scotomata. These are the neurological complications. Or patient might have the high blood pressure with hematological complications, like thrombocytopenia, where the platelets becomes less than 1 lakh. Or not only that, patient might have DIC, hemolysis, and pulmonary edema. And already Hannah told that it could be, nothing will be there, only preeclampsia, high blood pressure, proteinuria, and uteroplacental dysfunction. That could be evident by fetal growth restriction or abnormal umbilical Doppler or the stillbirth. So this is the definition of preeclampsia. When preeclampsia is defined high blood pressure with proteinuria, or preeclampsia high blood pressure with any or more of this organ dysfunction. Similarly, the classification has been changed. Before we had preeclampsia mild, moderate, severe. And for last few decades, it was mild and severe. Now the classification is being like that preeclampsia without severe disease. Number 2, preeclampsia with severe disease. So when we shall say that it is severe disease, when the preeclampsia has that dysfunction, end organ dysfunction, like neurological symptoms, hepatic symptoms, thrombocytopenia, renal abnormality, pulmonary embolism, or uteroplacental deficiency. So if those are present, then we can say preeclampsia with severe disease. And if those are available, those are not present, but preeclampsia with high blood pressure with proteinuria, we can call preeclampsia without severe disease. So this is the new classification. So as the preeclampsia has higher maternal and fetal mortalities, and there's no proper treatment, can you predict preeclampsia? Because if we can predict, probably we can intervene early to prevent the progression of the disease. Well, unfortunately, there's no single test can comprehensively predict the risk of preeclampsia, but there are different criteria which individually can predict, but when combined together, I mean, if we can get the algorithm, then the detection of preeclampsia will be high. The threes are specific maternal characteristics, uterine Doppler study, and placental angiogenic biomarkers. So what is the maternal characteristics? If we look at the NICE guideline, which is also adopted by SCOG and ISSHP, that women are at high risk when they have got the previous HDP, autoimmune disease, diabetes, chronic renal disease, hypertension, thrombophilia. And women are at moderate risk of getting preeclampsia. Those pregnancy was more than 40 years, whose BMI is more than 35, who are having multiple pregnancy, family history of preeclampsia, and pregnancy interval is 10 years. But, you know, that was done in the perspective of European women. So the Indian Justices Society, they did a wonderful job. They invented some score, which is very applicable for the women of this South Asia, like Bangladesh, Pakistan, Nepal, India. So the Justices score is almost same. One or two criteria have been added here. And the beauty of the Justices score is that they have the score is 1, 2, 3 allotted for each clinical factors. I mean, they have given the scoring system of the each event according to the gravity of the disease, which helps to get the score. And if the score is more than 3, that women should be marked as high risk of getting preeclampsia. So next tool is the uterine artery Doppler study. And that is a very promising study. I mean, we all know the pathogenesis. I'm not going to discuss so much because I don't have much time. What is important that there's this faulty trophoblastic invasion that results the constricted vessel all over the body. So that is reflected by the uterine artery Doppler study. We can do this uterine Doppler study in 2 times, like in second trimester, that is in between 21 to 24 weeks, and the first trimester is 11 to 13 weeks. Very recently, Thakur and et al., they showed that risk of severe preeclampsia predicted by second trimester elevated resistance pulsatility index. So they have got a very good predictive value. Though the notching is no more significant, rather the pulsatility index, I mean, what is the resistance index? That is more important. And this is the score by our ultrasonographic colleague, that they have seen that 11 to 13 weeks is 2.35, 20 to 24 weeks, if it is 1.44, 30 to 34 weeks, if it is 1.17, this group of women are at high risk of having preeclampsia future. Placental derived biomarkers. It is a wonderful, I mean, very, very revolutionizing predictive markers, because we know that angiogenic factors, that is soluble FLT, placental growth factor, these are the important characteristics or biomarkers that facilitate second or third trimester prediction of early onset and late onset preeclampsia. The SAPPHIRE study, which was conducted in 2018, and they showed that yes, there's 80% specificity and 90% predictive preeclampsia. So it can be suggested for the screening. Actually, there are huge lots of placental biomarkers like placental growth factor, soluble insulin, VEGA, and soluble FMS like tyrosine kinase. But most importantly, the Pelican study showed that if placental-like growth factor is less than 100, then there's a chance that these women will develop preeclampsia within 7 days of time. And if the FLT and placental-like growth factor ratio is less than 38, should be excluded very precisely, rule out 99.3% that these women not have preeclampsia 7 days. But if the SFLT, soluble FLT, and placental growth factor ratio is more than 85, that is very dangerous. And that indicates, that predicts that yes, there could be, preeclampsia and adverse outcome within 2 weeks. So these are the important things which helps when we are in controversy. When we are in clinical dilemma, whether a patient should be admitted or not, at least when they exclude that within 7 days, she wouldn't have preeclampsia, we are assured. So the algorithm is very helpful, and it is then the Sul-Udin Kupuk and the Holger Stephen all have the beautiful study, and they noted that yes, the combination of the biochemical markers with them gives a good predictive value for the preeclampsia. Well, the diagnosis is a very simple. Actually, though there is a clinical presentation varies, we have to carry out the full clinical assessment at each antenatal visit. We have to look for the symptoms, signs, and of course, we'll take the blood pressure. And there are a lot of variable presentation, starting from headache, blurring of vision, and so on. Then if I'm suspecting, particularly I have to take the scoring system, whether she is fitting on the score, then it will be easier for me. Yes, she might have a preeclampsia. Then with her symptoms, then you have to go for the investigation. Though if even she doesn't have a particular liver problem or hematological problem, apparently we have to do all the tests. We should not be miser. Complete blood count, liver function test, kidney function test, serum, smear, LDH, and creatinine ratio, protein creatinine ratio, everything we have to do to exclude. And of course, urinary protein, ultrasonogram, and ophthalmoscopic evaluation is very important for the management. And then we can decide what is the classification. Is it a preeclampsia without severe disease? Then we can manage this patient outpatient basis. Or if it is, preeclampsia with severe disease, then you have to admit. So once there's a main goal, that maternal assessment, why you should do very closely. We have to, early detection of deterioration of any sign, any symptoms, that is very important. And the fetal antenatal surveillance, you all know that there should be pictured per abdominal examination, to have the look at the fetal heart rate, CTG, biophysical profile, umbilical droplet, if it is indicated. Well, if there's a preeclampsia with severe disease, definitely you have to admit the patient and treat her as inpatient. And the principles of treatment is that we have to assess the patient first. And then, of course, we have to prevent the convulsion, we have to prevent hypertension, and we have to maintain the fluid balance. At the same time, the very close assessment of fetus and mother to see whether there's any fetal compromise or maternal compromise. And we have to plan for that patient. What should be the timing, place, and route of delivery. And referral should be done if there's organ involvement, particularly in the rural areas. Community clinic, ward. Actually, our women are very oblivious to come in the main district hospital. And so, we have to disseminate the information that they have to come to the tertiary hospital. Then timing, sorry. I just want to mention a simple thing, that measuring blood pressure. This is very important for the students actually, that when you're measuring blood pressure, we have to use appropriate size cuff. Sometimes the women are quite fat or edematous, so we might need the larger cuff. And preferably at least 30 minutes after ingestion of caffeine and after 5 minutes of quiet rest. This is very important. And patient should be comfortably seated with uncrossed feet resting on floor. And the chair should be in such a way that her back should be supported, her arm should be supported. And of course, blood pressure we have already told, but it is mild hypertension when it is equal to or greater to 140/90 in 2 occasions 4 hours apart. And if it's 160/110, then it could be severe preeclampsia. And that should be repeated in 15 minutes of time to avoid the delays in treatment. that is actually wrong seat posture of the women. Well, the billion question, the when to start the antihypertensive. There is a lot of controversies, debates, still debate is going on that why should we start, when should we start actually antihypertensive? In 2014, the Cochrane review said that there's no point of treating women with mild hypertension. I mean, 140, 90 to 100. They suppose that it should be started after 100. I mean, when they're above 100 diastolic blood pressure. But later, in 2015, the SHIPS trial, they said, or their study findings is like that treatment of preeclampsia with mild disease did reduce the risk of developing hypertension. And the second trial was done, which also that was published in New England Journal of Medicine, that they grouped two groups. One is tight control of blood pressure, another one is less tight control of blood pressure. The group where tight control of blood pressure was done, the diastolic blood pressure is 85, not below 80. That showed that this group of women had better outcome than who had less tight control of the blood pressure. Therefore, the current evidence support that controlling blood pressure to this level, at diastolic blood pressure 85, is beneficial. And recent Cochrane systemic review also showed that antihypertensive in the mild disease can reduce the incidence of severe hypertension by 50%. And also it reduces the neonatal death. That is one important issue, that whether the blood pressure should be monitored at home. And of course, that is optimum study. The finding is that women has to be taught that they have to take the blood pressure at home so that early identification is possible. So in Bangladesh, our community, this has not been, not that popular. So we have to disseminate the information. At least patient can go to the community clinic and they can check their blood pressure. Which hypertensive drug? Well, actually, there's no head-to-head randomized controlled trial to recommend use of one antihypertensive medication rather than any other, because all antihypertensive medications are effective and cross the placenta. Only ACE, that angiotensin converter enzyme, that are contraindicated in pregnancy. AOCG recommended that the use of beta blockers, that is labetalol, and calcium channel blocker as the first line agents for the treatment of hypertensive disorder pregnancy. Well, I'm not going into details because of time. For preeclampsia with mild, without severe disease, we can use labetalol, nifedipine, methyl-dopa orally. But when it is severe form, preeclampsia with severe disease, we have to prescribe parenteral antihypertensive drugs, particularly the labetalol and hydralazine. And it has also been said that if one drug is not controlling the blood pressure, we can add the second one. Seizure prophylaxis, of course, magnesium sulfate is the drug of choice. And the current preferred dose is 4 to 6 grams intravenously, followed by maintenance of 1 to 2 grams per hour. Importantly, nifedipine and magnesium sulfate should not be given together because there is a high chance that synergistic effect, there would be hypotension. The maintenance therapy, well, the therapeutic value and the critical value are very close together. That is why you have to check the patellar reflex, breathing, and urine volume. Unless they are satisfactory, we should not give the maintenance dose. Fluid balance. Well, our women are short stature, so 30 to 50 ml per day is enough. But if somebody is nil by mouth, then probably we have to increase the fluid, but not more than 80 ml per hour. Sodium restriction and diuretics is not advocatable at all. But of course, if pulmonary edema, we can take help of diuretics. Many doctors are fond of administering volume expander, but evidence doesn't say, because though there's intravascular volume depletion, but volume expander doesn't have any role. So if preeclampsia is severe disease, we have to give admission to the patient, and all the conservative treatment should be given to her. corticosteroid if we feel that she is going to deliver within 7 days. And if after giving all the treatment, if the patient is stabilized, then we can continue the treatment as expectant management. But if patient doesn't respond, definitely we have to proceed on the obstetric management. Obstetric management, once PE is diagnosed, the definite treatment is delivery. Why? Because delivery leads to the eventual resolution of the disease. But the timing of delivery is very, very important, and it needs experiences, because it depends upon not a single factor, the combined factor, including disease severity, maternal condition, fetal condition, and the gestational age. Close monitoring of mother and the baby is very important. So when to deliver? Well, delivery, usually if it is, patient is 37 weeks of pregnancy, preeclampsia is without severe disease, we can terminate the pregnancy after 37 completed weeks, that is 38 weeks. It is recommended, experts of the ISS HP consistently recommended this. And Hypertensive, the study clearly showed the benefit of induction of the group of women are at 37 weeks, that it is beneficial than expectant management up to 40 weeks. And intervention doesn't increase the rate of cesarean section, and there's a good increase in good maternal and neonatal outcome. But the thing is that when preeclampsia with severe disease, how long we can wait? Well, ideally, up to 34 completed weeks. If 34 completed weeks is passed, there's no point of continue the pregnancy because multisystemic organ is already damaged and there's uteroplacental deficiency. So most of the school of thought is that we have to deliver these women at 34 completed weeks. But that is not always possible. We have seen in our practical work that many of the women at 31, 30, 28, 32 weeks, the patient's condition deteriorates. So you have to deliver. So that is why when you should go for immediate delivery, when the blood pressure is not being controlled, even after addition of 3 classes of drugs, or the biochemical markers are deteriorating, and patient is developing neurological features like eclampsia or impending eclampsia. In that case, we should not wait till the 34 weeks. And of course, another condition like a placental abruption, reversed end diastolic flow, non-assuring CTG. If the fetal antenatal fetal surveillance is not satisfactory, probably these will guide us to deliver immediately. Where to deliver? Definitely, it is in tertiary hospital, not even in Upojela, that center. So that is also to disseminate the news to our healthcare providers, our doctors, and the patient. They have to have come in a tertiary hospital because high dependency unit is needed. And mode of delivery, well, preeclampsia, eclampsia, and hypertensive disorder is not the indication for C-section. So there's no point. It depends upon the gestation, Bishop's score, fetal condition, maternal condition. And even Bishop is poor, we might use the misoprostol to induce for the induction. Interpartum care, well, this is same. Respectful maternal care should be there, but important thing is that during interpartum period, there could be eclampsia, there could be heart failure. So very cautiously, we have to balance the fluid and we have to expedite the second stage by forceps or ventus. Proper analgesic should be there and AMTSL should be performed and no argametrin. And we have to keep in our mind that we have to ready MDT, multidisciplinary team, and neonatologist beforehand. Postpartum care, well, hypertension is leading cause of postpartum and readmission. And the postpartum complication also induce the de novo preeclampsia. Around 1/3 of the eclampsia occurs during this postpartum period. But unfortunately, there's no evidence-based clear-cut guideline at what time, how should we look after this patient. But definitely, we are going to have close monitoring for her, blood pressure checking, biochemical, biochemistry has to be seen whether it has been normal or deteriorating. And WHO told that we have to evaluate this patient at least within 72 hours and 7 days postpartum. If everything is fine, they can be discharged. Actually, the early identification and management is the pivotal because these women are at high risk of stroke, seizures, pulmonary edema, renal failure, congestive heart failure, and death. And postpartum hypertension is the surrogate markers for the future cardiovascular disease, renal disease, and metabolic syndrome. So you have to keep in your mind that these women need a regular follow-up. Preventive therapies, only one slide, because there are lots of drugs have been invented as a preventive therapy, like aspirin, calcium, vitamin C, fish oil, garlic, vitamin D, folic acid. But only evidence-based are regular antenatal checkup, aspirin, which reduces 62% of risk of preeclampsia, and calcium. It has been seen that particularly in our Asian country, that the risk of the incidence of preeclampsia is higher in the area where calcium intake is low. So WHO has recommended that calcium supplementation at high dose, like 1.5 to 2 grams daily, should be given in second half of pregnancy. Conclusion, I would like to conclude that hypertensive disorder pregnancy, significant cause of maternal and fetal adverse outcome. Preeclampsia is the cause of maternal mortality after the PPH. Improvement in prediction, prevention, early diagnosis, and management are crucial to prevent death. Public awareness for this dreadful disease is very, very important. And low-dose aspirin, regular monitoring of blood pressure may prevent morbidities from women to increase risk of preeclampsia. Thank you very much for your kind attention. Let's end preeclampsia and hypertensive disorder to have healthy mother and healthy baby. Thank you very much.
Thank you, madam. Thank you for your wonderful presentation, madam. And it's a recent updated and evidence-based presentation, which is very, very much helpful for our mid-level and the young doctors to learn on it and for the protocol-based management of hypertensive disorder in pregnancy. So thank you very much for the wonderful presentation, Professor Sheikh Zinata Nasrin. Your talk always enlightened us. Thank you, madam. May I now take comments on presentation? To give the comments on presentation, I'm now requesting Dr. Tasbirul Islam, the Honorable Chairman of the Planetary Health Academia. Over to Dr. Tasbir, please, sir.
Thank you, Sharmin. I want to apologize for some late coming to and joining the session today, but it was a very incredibly powerful and rich presentation. I learned a lot today. I want to not only thank Atapa for her wonderful presentation, but also giving a presentation on PHA platform. Really, I want to thank from the bottom of my heart. So, as intensivist and pulmonary physician, I don't see many eclampsia patient, but I see a lot hypertensive patients, even in either is urgency or emergency. So listening to your presentation today, I learned a lot, no doubt about that. So I'm pretty sure I will, and all the participants and the audience learned from your very rich presentation. My questions to you as a pulmonary, we see a lot sleep apnea patient. I know it's obstructive sleep apnea is one of the risk factors for the gestational hypertension or eclampsia or preeclampsia. So how do you screen sleep apnea patient? Do you routinely screen in Bangladesh for the sleep apnea or obese patient? That's number one. I have question. And second questions I have for Jinatapa is the diet. Especially rich in salt, sugar, or and the fat can predispose eclampsia and preeclampsia. And the other questions I have that here we actually do. We actually approach multidisciplinary way, right? We involve the cardiologist, internal medicine. We involve the intensivist if the patient, in preeclampsia may go to the ICU, obstetrician, dietitian, all this. Do you do this practice in Bangladesh? So that is my three questions, and I'm sorry too many questions I asked because I want to learn a lot and from you, and you're very learned and very rich presentation. I learned a lot today. And secondly, I want to say something about our global summit in February 2024, because there's a big portion will be on OBGY. That is we are planning to do. And I know Rehana is working on, and I know Sharmin is also working on, in collaboration with all the advisors from the OGSP, to finalize the details, including the topics, speakers, home and abroad, panelists, and chair session. But I think I want to meet with all the advisors from the OGSB, because I think there may be a clash between the OGSB conference in February and our conference on 23rd, 24th, because our one is a multidisciplinary or multi-speciality conference involving at least 10 subspecialties. It will be very hard for us to change and the dates, because it's too many people involved already. Only 10 discipline involved. Multiple guests from different countries are involved. So it will be very difficult. I really appreciate your help. So whether you can do your conference in a different time, but we can talk about it. So I think Sharmin is working on getting the meeting with the advisors. So thank you so much, Jinatapa. Thank you so much, all the panelists, for giving me a time to talk about it. And I got the opportunity to learn so much from you today. Thank you, Jinatapa.
Okay, most welcome. Thank you again for you to invite us for the conference. And thank you for your kind words. Your question, according to your question, I will start from the last question. You asked for the multidisciplinary team. I have mentioned here that we all of us, all the OB/GYN, we are always take help from our multidisciplinary team. That is the good practice in Bangladesh. Your second question was the diet. Well, the recent data is telling that there's no role of restricting sodium. Though normally without preeclampsia, any hypertensive patient, we are restricting the sodium intake, but actually sodium intake doesn't modify or doesn't prevent the progression of the disease. But in general, we are not taking too much salt. And your first question was obstetric apnea. Frankly speaking, I have to admit, we actually don't take it as a risk factor, so we don't ask unless the patient is complaining to us. I know only this one. I didn't ask patient whether you have got any obstructive apnea, but I don't know whether other OB/GYN specialists they are doing or not. And regarding your conference, Professor Farhana Diwan, madam, she might answer very well. Thank you so much.
Thank you. Thank you, Professor Zinata Nasrin, madam, and thank you, Dr. Tasbih, sir, for your nice addition. Now I'm taking the comments from our honorable chairperson. Firstly, I will go to Professor Farhana Diwan, madam. Professor Farhana Diwan, madam, is a proud chapter of Bangladesh, and she is working for a very, very hard work now as the president of the OGSP. And it is delighted for us that we have 172 participants now in the Zoom. It's a very much busy and working day in Bangladesh. It's Monday. And it's a very much privilege that 11 outside country other than Bangladesh, the participant from 11 countries joined with us. And Dr. Bushra from Afghanistan, she has also joined with us and mentioned that to mention her name, that she joined from Afghanistan with us. So Professor Farhana Diwan, madam, we want to know about, there's different protocols, but OGSB have our own protocol to management this sort of cases. And we have a management protocol in different health facilities, services in our country, because we start from the primary healthcare up to the medical college level. So what is your take-home message as a leader of OB/GYN society nowadays? So madam, what do you want from your young doctor and who are leading with this sort of cases in different level of the health facility? What your expectation from them, and what's your take-home message also? Over to Professor Farhana.
Thank you, Dr. Sharmin. First of all, I'd like to thank this platform for giving me this opportunity, because eclampsia is a very favorite topic for me, and I would like to, I'm dreaming of the day when Bangladesh will become eclampsia free, or the incidence we can reduce. We are not being able to reduce it. And because still eclampsia is accountable for 20% of maternal death in our country. We know the cause, we know why it's occurring, but we know the treatment, but we are not being able to reduce it. Of course, it means that less work is being done at the levels, at all levels of facilities. We need to do it, and we are trying hard to reduce it. And the two things needed for this is, number one, timely diagnosis and detection, and timely diagnosis and prompt management. And very recently, we have also added the detection part in it. Now, regarding the protocol, well, we have a very structured protocol for the management of eclampsia, and we know, Dr. Jinath has already mentioned that there is the principles of management. So when the disease is divided into preeclampsia, mild preeclampsia, severe preeclampsia, and the eclampsia itself. So this is the management protocol for our, thank you. This is the protocol where we have already prepared this protocol from OGSB, and we have the magnesium sulfate is a magic drug which is used in our country, and it is magnesium sulfate is very cheap, available, and it does wonders. So we have got 2 doses of magnesium sulfate, but one is the IV-IM dose and one is the only IM dose. And we have another locally made only IV dose, which is preparation, which is nalipsin. We are not using it much, but we use it when magnesium sulfate is not available at that point. Regarding the where we are using it, you can see, I think all of you can see the slide, where in the first we have the loading dose, and in the IV-IM protocol, the loading dose is given, the loading dose is 10 gram, which is divided into IV and IM. And then the maintenance dose is given 2.5 gram in alternate buttocks, 4-hourly IM for 24 hours, beginning from the delivery or the last conversion, whichever is the latest. So this is the protocol. But the problem is that you have asked me to mention about the facilities at different levels. Well, our doctors, our consultants, this is the health infrastructure of our country, and we can see that at all levels we have got service providers. So in the UHFWC, the grassroots level is the community level, community clinic. We don't have the doctors there, but beginning from after that, we have the UHFWC, where we have the medical officer there, and so they can give the initial treatment. Then we have the Upazila, where the consultant comes in and the cesarean and everything is done. And after that, of course, the district hospital there and all that. Can you show the flow chart before this one? Okay, if you do, yeah. So this is the tiers where in our country, how the facilities run. And you can see on the left side, there is the medical college hospital at the tertiary one, and on the right side, you can see the district, Upazila, union. Okay, so now I'd like to just mention at what level what is done. So I think many of us, like we have Lailapa, Roshanapa here, you all know, Saminapa is also here. So we all know that we have the emergency obstetric care. When it started in 1993, we used to divide the service into obstetric first aid, basic EOC, and comprehensive EOC. Obstetric first aid means only giving 3 injections, Maxal for eclampsia, oxytocin for PPH, and of antibiotic for septic abortion. And when it comes to basic EOC, the center will have all these facilities and normal delivery and management of eclampsia with the loading dose of Maxal and the maintenance dose as well. And then these women can be referred to the tertiary center for other facilities, for maybe for cesarean and all that, which is the comprehensive one. So the service provider is able to do this, and service provider can refer the woman to the next center for this. So the eclampsia management, now the question is, why are still the women are dying? Because we are not being able to send this patient. The last question, last comment, my comment is that regarding the only IM protocol, why this issue came? This issue came up because our service providers who are delivering at home level, that is the CSBS and all, I don't know, in India, they have a different name maybe. So when the woman detects the eclampsia case, she cannot do the IVIM preparation regime. So they have been taught they have been trained how to give the only IM. That is the whole 10 gram will be given in 2 buttocks, 10 ml, 10 ml IM in each buttock. So the whole 20 ml will be given. It is a 50% solution when the initial dose is given. And this is because the women then will be referred to the tertiary center. So before ending, I just mentioned that very recently we started the gestosis score in our country as well. And our colleagues from India, they know very well the chairperson, and also we have got Dr. Lakshmi and Dr. Charmila. They know about the risk factors and how we can manage these cases. We have just started it very recently, and I think that will help to detect the women in the antenatal period. So, and before ending, another thing, the role of antenatal care is very important, because in a proper quality ANC, we can do this. And we have our colleagues where because I am taking the lead of OGSB at this moment, and I would like to, it is my dream to start the quality ANC, because the latest our BDHS has recommended that quality ANC should be given, where we will look into the one visit by one medically trained person, 4 visits, and see the blood pressure, weight measurement, and everything. So I think that will be maybe a turning point for diagnosis of eclampsia cases and management. Thank you so much for giving me this opportunity. Thank you.
Thank you, Professor Karnadhan, Madam, for your wonderful addition in our country aspects. And also, Madam, in your leadership time in Bangladesh, we are doing the huge academic work, scientific work, and also in the field level activity. So we hats off on your leadership, and hope in your leadership, Bangladesh will reduce the maternal mortality and morbidity due to the hypertensive disorder in pregnancy. Thank you, Madam, for giving us your valuable time within your busy schedule. Thank you very much.
Okay.
Now I'm taking another chairperson remark. We have the chairperson of ICOG, Indian College of Obstetrics and Gynecology, Dr. Lakshmi Shikande, Madam. Madam, would you please add here? Dr. Lakshmi, Madam.
I think she's left for an emergency, Sharmi.
Okay, then we will take when Madam will join. Now I am requesting Dr. Jayashree Shah, the co-moderator of today's session, to continue the rest of very exciting part, the panel discussion and other take-home message part. But before that, the participant from 11 countries, I'm really my heartfelt thanks and gratitude to the participants who are joined from different 11 countries to today's session. Thank you very much. Now over to Dr. Jayashree Shah to continue the rest of the session. Papa, please.
Thank you, Dr. Sharmin. It's very pleasure to me to conduct the rest of the session. Now is the time for panel discussion. There are expert 4 panelists among us in today's session. They are Professor Laila Ajuman Banu, Madam. She is the Chief Consultant and Head of the Department of Obs-Gynae, Lab-Aid Specialized Hospital, Dhaka, Bangladesh. She is the President of PCOS Club of Bangladesh, past President OGSB, and past President Bangladesh Perinatal Society, and Treasurer FSSB. And our second panelist, Professor Fatima Rahman Pinky, Madam. She is the Professor of Obs-Gynae, Head of the Faculty Reproductive Endocrinology of Dhaka Medical College Hospital, Chairman of CME Committee of OGSB, Joint Secretary of Medical Education in BCPS. And our third panelist is Dr. Rehana Jaman. She is the faculty lead of PHA, consultant of obstetrician gynecologist at Nobel's Hospital, Isle of Man, UK. She is the member of various societies, including the British Society of Gynecological Endoscopy, British Society for Colposcopy and Cervical Pathology, member of the Advisory Committee Bangladesh Liaison Group of RCOG. And our another panelist is Sharmila Ayabu. She is the Vice President-elect FOXI for 2024. She is the Chairperson of Clinical Research Committee FOXI, ICOG Governing Council member, and she is the President, Menstrual Hygiene Management Consortium, and Secretary of the Gestosis India Association, and Secretary of the Academia Wing of Assisted Reproduction, TRICHI. Welcome our 4 panelists, and now we're going for the question answer part. My first question is to Professor Lala Arjuman Banu, Madam. Madam, actually, we enjoyed a lot of things, a lot of discussion from our respected Zinata Nasrin, Madam. I want to know from you the best and safest ways of fetal monitoring of HDP mothers and preparedness of newborn management. Madam, will you focus on your question?
Thank you, Joyশ্ree. First of all, I must pay my gratitude to PHA, the Planetary Health Academia, for including me in this very important webinar. And also I give a great thank to Professor Zinata Nasrin for her wonderful presentation, and always she do this. So I think it is a very important topic in our day-to-day practice, and also in also globally, because still the main etiological concepts or what is the causes are not known. So there is different guidelines and different protocols in each variable centers for the management and for maternal management, and also the fetal surveillance. So for fetal surveillance, we should first of all do that the mother should be aware about the complications of pregnancy-induced hypertension on the fetus. Because if a mother knows that there is adverse effect on her fetus, then they should be aware. Because sometimes we advise them just when blood pressure is 140/90 that you must take some antihypertensive medicine. But they don't take it, and ultimately come to us with eclampsia. So I think awareness is very important, and especially as I think somebody has said that antenatal care, Farhan has said, I think, during antenatal care, we must give awareness to them, because if she takes the antihypertensive medicines, or she should come regularly for antenatal checkup. This is one. And then if there is any warning sign that she is gaining weight and she has a blood pressure slightly rising, especially after 20 weeks, then we must do the Doppler velocimetry, and we can then see the adverse adverse signs of sorry for my voice, adverse signs for getting development of the pregnancy-induced hypertension. So for some tests like serial ultrasonography for the growth profile, how much of the baby is getting weight, and especially if there is but the other tools are biophysical profile and the velocity I have already told, biophysical profile and day-to-day key count, and the other tests like amniotic fluid volume like this, and sometimes modified biophysical profile may be done. So if these all the tests are okay, or the normals, then we can allow her to continue her pregnancy, and also to keeping a supervision, close observation to her. And in the mild cases, they need not need any admission, but when there is the blood pressure is rising, not controlled with the antihypertensive drugs, then sometimes admission should be done. And mainly the complications, what the complications are, fetal complications like risk of there is low birth weight, small for gestational age, neonatal death, enterocolitis, RDS, and bronchopulmonary dysplasia, increasing nephrocolitis, enterocolitis, and retinopathy of prematurity, and decreased breastfeeding also. These are the complications. So it should be counseled and aware to the mother that these are the complications. So you must be regular with for your antenatal checkup, and if there is any warning sign, she should actually know the warning sign of developing the severe preeclampsia or eclampsia. This is one thing. And there is one guideline from the ACOG, and they advise that the testing should be done at 32 weeks, 34 weeks, and at 39 weeks if it is not, she is not delivered. So this is the protocol, and there is some difference in the all the protocols, but more or less they are same. So we must follow one protocol, or sometimes it depends on the expertise of the treating physician and also the protocol of the center to center variation. But there we should also remember that individualization should be done, because not all the patients require the same monitoring or same surveillance. And one interesting thing I have noted that nowadays it is believed that the spectrum of autism spectrum disorder also it is a result of the pregnancy-induced hypertension. In some studies they have found, and also the attention deficit and intellectual disability. So I think there are more researches there is going on, and we will know that there's some new findings of the fetal condition, and the fetal surveillance should be more closer. And I think after delivery, our NICU colleagues or the neonatal colleagues, they will take over the babies and they will manage accordingly. But especially if needed, they can put her in his or her to the NICU or neonatal care unit, or they can be managed outpatient department. Sorry, I'm so sorry for my voice. So thank you very much again for asking me the question. And I think I have covered up everything. And if there is any question, then I can take it. Thank you so much. Thank you, Dr. Tasvi, for Fazana, and our guest from UK. Thank you very much.
Thank you, madam, for your valuable opinion. Now I want my second question to Dr. Sharmila. Nowadays, we are seeing that a lot of pregnancy are occurred by ART technique. Madam, majority of ART pregnant women have HDP, that is hypertensive disorders in pregnancy. Can you put some light on this topic? Is there any relation with ART and HDP? What is your opinion?
Thank you so much, Dr. Joyshri, for that question. I would like to thank Sharmeen for the opportunity. I'll just share my slide and I'll show like how it is important that we need to be extremely careful when you're having an ART pregnancy, because there are certain indications that these cause more of preeclampsia. And when you see the American statement in 2020, they've said the rate of preeclampsia has increased by almost 25% between 1987 and 2004. And for a lady who was giving birth in 2003, the risk is almost 6.7-fold increase from 1980. There's such a big difference in the incidence of preeclampsia as the lifestyle of women are changing. And you have to remember that risk factors are nulliparity, primipaternity. Suppose they change partners, again they have got a higher risk of preeclampsia. Advanced maternal ages, previous preeclampsia, a high body mass index which is causing havoc now in women's health, diabetes, multiple gestations, and especially assisted reproduction. And when there's a pre-existing medical condition along with her infertility, it's going to add on to the problems. And there's an ascending trend, and they have attributed that increasing slope in the BMJ to increasing use of ART, the incidence of hypertension in women even before they become pregnant, diabetic women, obese women, and there are early diagnosis problems. And sometimes when you don't predict and prevent, as Zeenat was saying, that's going to cause an increased instance of preeclampsia later on. And there was one study in 2019 which has said, when you use ART treatment for managing infertility patient, remember there's almost a 1.71-fold increase in the incidence of preeclampsia in her. And it can happen just because it's an ART pregnancy. It doesn't even need to have an additional factor. Just because she undergoes an assisted reproduction, it's going to increase the chance of preeclampsia. It's very, very common in donor oocyte programs, and it's got a very high incidence in frozen cycles. And why it happens in ART pregnancies is there is an abnormal placentation which happens in ART techniques. And when the blood flow is compromised and diminished, it's going to cause obstetric complications later on because the placenta is compromised even before it starts. And the insufficiency can also happen because of the altered hormone environment. When you have too much of hormones because of your stimulation protocols, or in a frozen cycle, when you give estrogen and progesterone in high doses, that's going to cause an altered environment, and that can lead on to placental insufficiency. But remember, ART can also have an epigenetic effect on the mother and the fetus, and that's going to cause problems, and that can lead on to preeclampsia. And why it happens in donor gametes is, we always think that the placenta is a villain in the development of hypertensive disorder in pregnancy, but it's not so in every pregnancy. Now they're saying the placenta may be actually the victim. It's not the villain in all cases, because there's a role of maternal immune reactivity against foreign fetal antigens, as well as the donor gamete, which is not hers. And that's going to cause a high incidence of preeclampsia. There's a 25% increase in preeclampsia and donor gamete pregnancies. And you have to remember this when you're going to use donor gametes for ART. And regarding frozen cycles, the reason which is attributed to an increasing risk of preeclampsia is the absence of corpus luteum. In a frozen cycle, you would have actually downregulated her, given her estrogen progesterone for the endometrial preparation. So they don't have a corpus luteum at all. And when corpus luteum is not there, it actually secretes vasoactive hormones like relaxin, which was not seen in these artificial cycles. And when relaxin is not there, they say it compromises the maternal cardiovascular adaptations to pregnancy. And that's why we say that placenta is not the villain always. It's also sometimes a victim also, because when the mother is already having a maladaptation to the pregnancy with the cardiovascular system, she's going to land up with preeclampsia later on. And that's why frozen cycles are notorious for causing preeclampsia in women who are undergoing ART pregnancies. And remember, when a lady has got recurrent miscarriages with her other methods of management, and she's then gone for an assisted reproductive technology for having a pregnancy, remember the chance of preeclampsia doubles and triples now, because there is a common pathway between recurrent spontaneous miscarriages along with infertility treatment for patients who are having prolonged periods of infertility. So the chance of preeclampsia is almost like doubled in these patients. There are other associations also, because multiple gestations are much more common in ART techniques compared to natural spontaneous conceptions. And those are that's actually a 2.1-fold increase in preeclampsia in women who conceive spontaneously, when they compare to women who conceive spontaneously. And when there is lower estradiol hormone levels when on the day of HCG stimulation, when you're going to do the pickup, they say that relates to a higher incidence of preeclampsia, and also the higher pregnancy weight gain which can happen in these infertility patients, that can also cause subsequently preeclampsia. And there's one study in 2020 in fertility sterility where they have said when a lady with adenomyosis undergoes ICSI and she conceives, there is a uteroplacental malperfusion during the first trimester, and they say that leads on to preeclampsia and complicates the perinatal period also. I'd like to thank Sharmeen for the opportunity. Thank you so much.
Thank you, madam,
Thank
for
you.
your experience sharing with us. Now I am going to Dr. Fatima Rahman Pinky, madam. Madam, you are working in Dhaka Medical College Hospital, the largest hospital in our country. You are dealing lots of emergency obstetrical cases. Would you please share the data indicating last 1 year admission of severe preeclampsia and eclampsia patients? What protocols you were following when dealing with severe preeclampsia patients, and put some light on newly established ICU, obstetrical ICU in Dhaka Medical College Hospital, madam.
Thank you, Jayashree, for your questions. Actually, there are lots of questions, but I think I can answer you. And also, I am thankful to this academy for giving me opportunity to talk about this important topic, and also thankful to listen to the all eminent speakers. Now, you know, the Dhaka Medical College is the largest tertiary level hospital, and patients with different sorts of disease, especially preeclampsia and eclampsia, are sometimes they are referred from other centers, and sometimes they got admitted directly into the hospital. And not only with preeclampsia or eclampsia, but the patient can with some other medical comorbidities like HELP syndrome and thrombocytopenia. Sometimes they come with severe jaundice, sometimes they come with some other disease like uncontrolled diabetes, or also they come with renal failure or liver failure also. So all of these, as it is a tertiary level hospital, all these patients are dealt with by multidisciplinary approach. Regarding the data about the year 2022, the total of admitted obstetrical patients were 12,789, and among them the total hypertensive patients were about 2,440, that include about 19.8% of the all obstetric patient. And preeclampsia patients, there are 1,337, that means it comprises about 13.22%. And among them, antepartum eclampsia is 10.6%, and postpartum eclampsia is about 310, that is 2.62%. And regarding the delivery, we know the obstetrical management plays a very crucial role in the management of preeclampsia and eclampsia. So the vaginal delivery, as the maximum patients come at around 26 to 32 weeks of gestational age, and there is placental insufficiency, and there is signs of fetal growth retardation. So this patient, the number of vaginal delivery is about 720, that means comprises 13.55%, and the outcome in vaginal delivery is better than cesarean section. And the incidence of cesarean section is 11.27%, and the 304 patients, that means 3.2% patients were treated conservatively. And the maternal death is high. Among the 12,300 patients, there was 52 maternal death, and eclampsia and the liver renal failure, especially patients with renal failure and the left ventricular failure. This patient died from the around number is 17. So, recently we have started the obstetrical ICU and SDU, and recently this year, I think at the end of this year, the critically ill patient will be managed more with more care, critical care expert. So the incidence of maternal death will decrease, and morbidity will also decrease. And regarding the protocol, already Farhana Madam has said about the protocol existing. We practice the usual protocol, that is the IVIM protocol, and sometimes we also practice the IV protocol also. And regarding the management with other multidisciplinary approach, we consult with the medicine specialist, endocrinologist, and other hematologist. We get a good support from them. Also our critical care experts also. So we are trying, but at the end of the day, still now the death from eclampsia and mortality and morbidity from preeclampsia and eclampsia is more, and we are hoping that when by improving our antenatal care and early detection of the cases and detection of the high risk cases will decrease this incidence. So thank you.
Thank you, Madam, for sharing your practical experience with us. Now I am going to Dr. Rehana, our one of the panelists of this session. Madam, what's the protocol in UK you maintain? I want to know about that. And is it similar to our country, or it is different bit? Madam, can you share your experience, Madam?
Thank you very much, Jasri. Thank you. But I like to thank, first of all the speakers, especially Zinat Appa. I always learn a lot from you. It was a very nice presentation. Same to Farhana Dewan, Madam, that she actually shared the protocol, and if every level of Bangladesh, which I think all the participants, especially from any developing country, will be delighted to know there is a protocol exists, and according to the facility, there is a detailed discussion was there. I learned quite a lot from Sharmila about ART and the risk factor for the preeclampsia. Yes, they are the high risk population because I think they in UK experience, they're elderly moms, they are high BMI, they have got other risk factor which causes them to be the high risk for preeclampsia as well. So yeah, I actually quickly go through, I made some presentation. I'm just going to share my screen, and I overall going to just go from the preconception up to the postnatal period. So I'm just going to share my screen. Please bear with me. Thank you. So I'm just going to give a small update on the hypertensive diseases in pregnancy. Zinatapa has already gone through all the definition, but I'm just going to share this screen where I'm just going to summarize. So as we all say, blood pressure more than 140 by 19 is the reading, is the one of the criteria for preeclampsia. But we divide it into two groups. One is, sorry, I think. One is less than 20 weeks pregnancy, and one is more than 20 weeks pregnancy. So as you can see, in less than 20 weeks group, there'll be three groups. One is the chronic hypertension. So they will all already been diagnosed with the hypertension, and there will be evidence of proteinuria, dyslipidemia, or any organ dysfunctions. They can have abnormal ECG, abnormal liver function, kidney functions. And then there is a group called white coat hypertension. Usually their blood pressures are high in the clinical settings, but normal at home. But I think Zinatapa already said that we shouldn't ignore them as well, because they will be also at high risk of having preeclampsia. And then a group called masked hypertension. Their BP is high only if outside the clinics and without the involvement of target organs. But these people are also at high risk of developing preeclampsia. Then we go to the more than 20 weeks pregnant. There is preeclampsia, there is transient hypertension, and there is gestational hypertension. There's three groups. So I've already mentioned the preeclampsia group will have involvement of any of the organs. It can be kidney, it can be liver, it can be neurological or hematological. And then the group which is transient hypertension, their blood pressure normal after repeated readings, but this group also we shouldn't ignore. And then other group is gestational hypertension. They will have only high blood pressure, but no other evidence. But this group also can later develop superimposed preeclampsia. So this, as a nutshell, the classification I just wanted to share with you. I'm not going to go through all the slides, but I'll just go to some of the important ones just to summarize this presentation. Now, we know that screening for preeclampsia, there is different criteria. And in UK, the NICE guideline says if they have one of the following high-risk factors or two of the following moderate high-risk factor, then they will be at high risk of preeclampsia. One is if they have history of hypertensive diseases, if they have chronic kidney disease, they have autoimmune disease like SLE or antiphospholipid syndrome, type 1 or type 2 diabetes, or chronic hypertension. If they have one of these high risk factor, they are very high risk for preeclampsia. And others are, if another group, if they have 2 or more of the followings, like if they're primary gravida, aged 40 or more, pregnancy interval more than 10 years, body BMI is more than 35, a family history of preeclampsia, and multiple pregnancies. Then also there is a Fetal Medicine Foundation. They have developed an algorithm which they developed over a series of observational studies, and they included maternal risk factors like blood pressure, placental biomarkers like pregnancy-associated plasma protein A, PAPA, pregnancy protein placental growth factor like PIGF, and uterine Doppler. And then the other one we all know is that according to the maternal characteristics. And when there's some study done to see what exactly beneficial, which screening methods are cost effective or beneficial. So as I said, one was the expected management criteria, like algorithm prediction model on maternal characteristics, one of our nice guideline, and another was Fetal Medicine Foundation. I'm going to just quickly minimize this slide, and I'm going to show you the Fetal Medicine Foundation's criteria, which is, it's not that we can actually use that practically in every day, but is very useful for the future generation to know about it. It's quite interesting. Can you see the screen now?
Yes, madam, we can see. But there
so
are
as you can see,
slides.
Here they assess the Fetal Medicine Foundation has developed this tool, and they have done into 3 different levels. One is 11 to 14 weeks, one is 19 to 24 weeks plus, and then 30 to 37 weeks. So what they have seen is the criteria are, if this is a pregnancy, singleton pregnancy, or is a twin pregnancy, then they were dating, this dating scan, what is the fetal crown lump length, then examination date they put it, date of birth of the mom's height, weight, racial origin, smoking, mother of the patient had any other previous family history of preeclampsia, especially the mother, conception method, whether they had it artificial, like spontaneous conception, or whether it was a ART. Then medical history, whether there's chronic hypertension, diabetes, type 1, type 2, SLE, antiphospholipid syndrome, obstetric history like nulliparous or paras. And then they went to the biophysical measurements like mean arterial pressure, mean uterine artery, Doppler, PI, date of measurement, biochemical measurements. So this is in a research setting, which is quite interesting, because we can see they have actually incorporated some of the day-to-day risk factor. We look at it here, but only thing they added with some biophysical measurements or biochemical measurements, which is they have used. So I'm just going to minimize this and go back to my slide again. So this is just to give you an idea what they have actually done. So when this study was done, it looks like that expected management should be used in developing countries. All these 3 methods are superior to no risk assessment, but fetal foundations and expect model being superior to the NICE model, and FMF model has good specificity, but is costly and difficult to implement. Because of its lower specificity, expect results in more over treatment, but the highest savings. Now, there is a role of calcium. We know that there was lots of questions, or there was lots of interest with the micronutrient or vitamins plays a role. Cochrane systemic review says, especially people who are deficient in calcium, they should benefit from like calcium supplements, but it's not routinely used. Now, what do we do as a part of the investigation? If we know that mom already has got hypertension before 20 weeks, then we can do a detailed medical history, cardiovascular examination, renal function test, liver function test and diabetic screen. And if we can add some relevant imaging, echocardiography, catecholamines, depending on the history and depends on which organ involvement are going to be there. Women with the chronic hypertension who are at risk of developing preeclampsia, most of the guidelines in the world, ACOG or COG NICE, recommend starting the aspirin for prevention. I think there was a question in the chat box, when to start the aspirin. As a UK recommendation, as soon as they have got, like if they have previous history of preeclampsia or hypertension or any of the diseases like SLE or antiphospholipid syndrome, we advise them to, as soon as the pregnancy test is positive, to start 150 milligram. So many of the time, the general practitioner or the midwife even going to tell them to start it. Or if someone has the preeclampsia in one pregnancy, at the postnatal period, we will counsel them and debrief them, saying that what they need to do for the next pregnancy. And that time they will be advised that next pregnancy, when they have a pregnancy is positive, they can start the 150 milligram. That's what we use in UK. Now, I think Zinatapa already discussed about the CHIPS and CHAPS trial, which both of them has said that the role of controlling the blood pressure. I think even 10 years ago, we used to think if they have moderate hypertension, then they're fine. We may not need to strictly monitor the blood pressure because we may cause the baby to have small for date or growth restriction, because that will going to cause a restriction of the blood flow, placental flow. But CHAP trial and CHIP trial both have said, no, even moderately high blood pressure, I think our goal should be control the blood pressure below 130 by 80. This is the standard protocol for the whole pregnancy. I don't know how you can actually, whether you can read it, but I'll just elaborate. One was that screening, which I have already mentioned. Prophylaxis is aspirin, and calcium has got little bit role, especially deficient population. In UK, the like ethnic origins or Asian origin pregnant ladies or reproductive age ladies, we ask them to have the calcium supplement. Then diagnosis. We know that blood pressure needs to be more than 140 by 90, and then any of the test of the organ involvement. Now about the medication, it will be antihypertensives. Commonly used antihypertensives in UK are labetalol, nifedipine, and methyl-dopa. For eclampsia is the magnesium sulfate, and so that's about the medication. Delivery, we already heard from Zinatapa that pregnancy is a disease of placenta, though we heard from the ART specialist that placenta can be a victim. It's not always the culprit, but is because their only treatment is to delivery, remove the placenta from the system of the mom. So we try to, if possible, take the mom up pregnancy up to 37 weeks. And then I think there is evidence that continuing the pregnancy is not going to be beneficial, but we know that because we're going to induce, there can be iatrogenic deliveries and then cesareans because of the failed induction. But here we have to prioritize mom rather than, I know baby comes second, but mom needs the priority. But we should keep a balance of both of them. And then it also comes the postnatal period. How do we monitor? In UK, we try to keep them 48 hours if they are moderate to high risk groups. But if they are mild groups and they have no organ involvement, they're stable, they can go home. But at the community level, the midwife regularly visits them at least for 2 weeks. After 2 weeks, general practitioner or GP get informed about that. They get a discharge letter from us about what we have done, what medication they were on, and then then the GP will control the blood pressure, because some of the ladies may, after the first preeclampsia, will continue to be hypertensive. This is the group we shouldn't forget, so we should keep an eye on them. So this about the standard
Thank you, madam.
of care.
Madam, we are already running short of time. Would you please complete your talk in 1 or 2 sentences? Just finish, madam. Please.
Okay, I think there was a question about the medication, the dose. It is in this presentation. I will be happy to share, but the commonly used medication are labetalol, methyl-dopa, and nifedipine. There is also intrapartum management of IV labetalol, IV nifedipine, methyl-dopa. Normally we try to stop after delivery, and hydralazine we use, but the commonly used medication is labetalol, IV labetalol. We all know magnesium sulfate is the important thing to prevent the eclampsia. And then other important thing I want to say is that potential underlying mechanism association with hypertensive disorder pregnancy and future cardiovascular disease. So these ladies needs to know they have got twofold increased risk of coronary heart disease, stroke, or death from cardiovascular disease, fourfold increase of the risk of heart failure with recurrent preeclampsia. So I think when we see that lady in the postnatal period, this is the time we should counsel them, we should involve the family, and they should be educated how to look after themselves and how to prevent it, start the aspirin and calcium for the next pregnancy. Thank you.
Thank you, Dr. Rehana Zaman, for your sharing. Now it's the time for almost, we are at the end of the session. There are lots of questions. There are lots of participants still now with us. I just want to ask 2 important questions to our keynote speaker, Professor Zinata Nasrin, madam. Madam, one of the question is waiting for you. That is, what is the role of metoprolol? Is there any use of antihypertensive metoprolol in pregnancy?
Well, thank you very much for the question. Actually, metoprolol can be used, but the thing is, we have to, the evidence-based, the labetalol is the better sympathomimetic drugs rather than metoprolol. Once we are using labetalol, if it doesn't work, we can add with labetalol and if it nifedipine or calcium channel blocker. If it doesn't work, then we can add hydralazine. So we need to jump off metoprolol, though it can be used. Thank you.
Madam, is there any role of ECG for pre-eclampsia patients?
Well,
Dr. Joyce, Dr. Charmila want to add here something with Zinath,
Yes.
madam.
Yes.
I agree with Zinath, but metoprolol is ideally used when you've got an additional cardiac disease, like cardiomyopathy or something is started, then it's a better drug because metoprolol can cross the placenta and cause more of neonatal side effects compared to labetalol. So it's better to be avoided, and labetalol will be the first choice of drug always. And regarding ECG, it's always ideal that you do in a preeclampsia patient because there will be an underlying cardiovascular problem in cardiac problem in many of them. So you should not miss out on a disease which can manifest later in her 3rd trimester. So it's better that you do an ECG and echo also, if possible, to find out the ejection fraction.
Yeah, Dr. Rehana already mentioned that they are doing that.
Thank you, Dr. Sharmila. Thank you, Professor Zinata Nasrin, madam. Now I want to take a comments from Professor Samina Chaudhary, madam, our past president of OGSB. Madam, can you give some take-home message in 1 or 2 sentences only, as we are already lag behind of time?
Yes. Actually, this is a very wonderful session, and I want to mention only one point. About 22 years ago, when I was in Institute of Child and Mother Health, we have introduced eclampsia box. I want to give emphasis on eclampsia box for readiness of the facility. Whenever one patient comes with eclampsia, within a minute, the treatment will be started if we are ready with eclampsia box. So in every labor room, there should be an eclampsia box which will contain all the initial management for a patient is needed. That should be for all the labor room management protocol. And I think that will reduce the eclampsia death very much. So this is my request, and that all the facilities should be ready with eclampsia box, and that will save our lives. Thank you very much.
And
Thank you,
actually,
ma'am.
the preloaded magnesium sulfate is available in India now. Because when you have an eclampsia patient, it's very difficult to load that 14 ampules very fast. By the time the eclamptic seizures will become very worse. So they've got a preloaded, like a IV set, IV pint. So you can just take it and you can start. And that,
Yes, we have got it.
That
In
readiness
Bangladesh, we
is
have got
nice.
it.
That
Yes.
readiness is very important, Madam. As you said.
Yes.
I got a question, Madam, Samina Madam. Is it available in every level in Bangladesh?
Actually, all these are available, but it is important to make a box with collecting all the drugs that is required for management of a patient. Only one patient.
Actually, Brianna, we are using now
everywhere.
the
That
labor room
we have to-
protocol. In all the labor room protocol, we are giving this eclampsia box and the PPH box. The labor room should be already they are from the government level. Already they have given the order also. All the labor rooms should keep the eclampsia box and the PPH box. And it is not all those things are we are regularly using, but they prepare the things in the timely. Yeah, that should be. They are using.
Thank you, Raushana Madam.
you.
I want
Okay,
to
I actually, Jayanti,
yes,
Joy,
please give your take home
only
message
one
for us.
comment is, I am just repeating the voice of Professor Farhana. Actually, we need quality ANC. In our country, only 18% quality ANC is still persisting. Only one visit ANC, 81%. Only 4 visit ANC, 48%. So we need quality ANC. In that quality ANC, we can check the blood pressure by medical graduate. We can take the urine for album. We can find out the danger signs. We can tell the patient to the danger signs. So if we start from the grassroots level with the quality ANC, then we can also control the pre-eclampsia. Actually, eclampsia is far away. So we have to be start these things from the grassroots level. And a very interesting thing, Professor Jinatara was telling about the white coat hypertension. Actually, it's very common. Most of the patients we are telling, you are in the hypertensive patient. No, I am also a normal patient. They are not taking any drug at home, in the grassroots level also, in our chamber also. Most of them, they deny, we are okay. But when they are coming to the chamber, we are already this in the 140, 160 by 90 or 100. So we have to be cautious about that. We have to counsel the patient regularly. And another question was, Rihanna, I think Tasbir left the session. 23rd February will be the BCPS conference. Actually, I know it is a regular system. The last Friday of a month, February, there will be AGM in the BCPS. So there will be a clash. I think so. We have to think about the date about our next conference. Yeah.
I think, Madam, we are going to have a meeting sometimes very soon with all of you as advisors.
I have.
Yes.
Can I make a comment?
Thank you, Raushana Madam. Now, yes, Madam, I am going to you. You were the last person. Please give take-home message from our OGSB.
Actually, I just wanted to comment. I wanted to inform Dr. Rihanna and others, like in Bangladesh, our government is very, very much involved with us in the management of eclampsia, in the management of PPH, and they have made the SOP, it is called SOP, Standard Operative Procedure, for each and every case. And so they're like Raushana was mentioning, they have with us, they know that we need the labor room protocol, and in the labor room protocol, every center has the eclampsia kit. And in the eclampsia kit, we have the injection Maxel, because there is no issue of cold chain or anything regarding Maxel. But the problem is that because of the, Jarmila was mentioning about the ready mix Maxel, we have got the, they can prepare the IM, for the IM, they can prepare only the, take it in the syringe and give it, not the ready mix. But Samina Appa was mentioning, but as far as I know, that only IM protocol is there, where they will take it in a syringe, in one syringe, 5 ml in one buttock and 5 ml in the 5 gram in one buttock, 5 gram in the other buttock. And the woman will stop convulsing and she will be sent to the center. So this is done, or everything is done to manage these cases upfront, on spot, and then refer. And of course, in the referral center, there will be the rest of the management will be taken care of. And in the tertiary care, we have the multidisciplinary approach, which Jinath was mentioning. And just one more thing I want to mention. I also gave Dr. Sharmin, she had the flow chart, which we have in our protocol. This flow chart is very clearly, it is spelled out that if a patient has mild preeclampsia, what will be done? Severe preeclampsia, what will be done? If the woman comes with eclampsia, what will be done? So this is not only the 32 or 34, even in mild preeclampsia, we can go up to 37 weeks. If everything is okay, assess the cervix and go for vaginal delivery. Sharmin, do you have that protocol with you? It was page 86 in our book. Sharmin, are you hearing? Okay, if you can't show that. And the severe preeclampsia, in the severe preeclampsia, we also have, this will depend. More than 34 weeks, less than 34 weeks, or if there is severe convulsion and if there is HELP syndrome, it will be. So these are very young. This is the one, it is very nicely defined in our guidelines. So people can go mention it. It is available in all levels of the facilities. That's all for me. I think that we have a lot to do in case of eclampsia and preeclampsia, and this was really a very good exercise we had today. And everybody has also, many people, students started, I think doctors and students asked a lot of questions, and I think it was very effective one. Thank you so much.
Thank you, Madam. Appa, is it possible to take 2 or 3 more questions? Because Dr. Charmila also.
Okay, no problem, but it's already 11:19. Okay, we can take 1 or 2 questions from the audience. One participant raise hand. You can ask one question to mention the name of your suggested one.
You can take question from the chat box.
Okay. One of the question, I also write lots of question actually. Should we continue maintenance dose of Maxal for severe preeclampsia, madam? Can you answer? Parna down, madam.
No. We will not continue the maintenance dose. When we give the maintenance dose, I have already clearly mentioned that the maintenance dose is given for 24 hours, 2.5 gram in alternate buttock IM 4 hourly from the convulsion or the delivery, whichever is the latest. So if a woman starts convulsing, we don't decide to terminate within 4 to 6 to 8 hours, because if she is in labor, maybe she may progress. So we see that, but if it doesn't, we go for delivery. So this will be from, maybe she convulses, the last convulsion is at 4 p.m. and she delivers at 6 p.m. So that will be the next day up to 6 p.m. we'll give her continue the maintenance dose, not more than that.
Madam, she asked about the prophylaxis. Should we?
No, she said whether we continue the maintenance dose.
In case of prophylaxis.
Severe preeclampsia.
Severe preeclampsia,
No,
not for eclampsia.
no. In severe preeclampsia, we'll give Maxal only. The loading
Dose only.
Yeah.
Oh, no, actually in UK, we do give a maintenance dose as well.
Most
So
of the
what
guidelines.
we do, even the severe preeclampsia, we give the loading dose and then we start the IV infusion, and that continues 24 hours from the starting, or if it is like 24 hours after the delivery, whichever is the longest.
Yes.
We don't give the IV infusion here.
My last question to Professor Laila Arjuman Banu, madam. Madam, which drug combination is best? What do you suggest? Which are the combined drug you can suggest for severe preeclampsia? Drug combination.
Unmute, madam. Unmute yourself, please.
Actually, I have gone through all the guidelines, and the suggestion is that you first start with the levotiroxam, and then if it is not controlled, then you start with either nifedipine or the alpha-meldopa. But in our country nowadays, we actually don't use the alpha-meldopa. But they have said that alpha-methyl-topar, if you started, then after 2 or 3 days of postpartum period, you must abandon or obsolete the drug. And the combination is levotalol and alpha-methyl-topar, levotalol, nifedipine. But you should not combine Maxalf with nifedipine.
Yes.
Any other?
Okay, now can I ask one more question to Professor Zinata Nasrin, Madam? Madam, there is a question. How can you differentiate severe gestational hypertension from non-proteinuric preeclampsia, where lab parameters are normal?
Well, thank you for the question. Non-severe.
Non-proteinuric preeclampsia and gestational hypertension, severe gestational hypertension. How can you differentiate?
Right.
Where lab parameters are normal.
Gestational hypertension means that hypertension after 20 weeks. And there could be proteinuria, but there will be no features of severe organ dysfunction. This is the most important thing. And severe preeclampsia, definitely. That means preeclampsia, proteinuria, hypertension, and there could be 1 or 2 more features of organ dysfunction. So that is why you can, the gestational hypertension, no organ dysfunction. That is the most important message.
Joyce, there was a question. Can I answer that? There was a question.
Yes,
Just it came in the chat box.
Yes.
That if there is there is seizure but no eclampsia, whether it can be given? Yeah, it can be given, because if there is a seizure, before confirming the diagnosis, whether it is, we take it as eclampsia, but it may later prove to be otherwise, but we can give the Maxalf for that convulsion.
Okay, madam. Now is the time to close the session. Actually, it's a very fruitful discussion, I think, because the last 2 hours we are going to discuss on a topic. Today, lots of questions are in the chat box, and Dr. Musarat Sultana Shumi is the best question asker for today's session. And a gift is waiting for you. You will get it on time.
Why?
Thank you, Dr. Musarat.
Why she's the best questioner?
Congratulations, Shumi.
Congratulations, but why?
Madam,
What was the question?
Dr. Sharmin, can you tell the reason? Dr. Sharmin.
You asked the last question to Zinat, madam. That's from the Dr. Musarat Sultana Shumi.
Yes.
So on ranking of the question, that was one of the best questions.
Okay.
What was the
Dr.
question?
Sultana is the associate professor in Sir Solimullah Medical College Hospital and very known face to our OGSB also.
Yeah.
Thank you, Dr. Shubham. So, dear audience who are throw out the time with us, and our learned panelist, as well as the keynote speaker, we are very much thankful to you. And the chairpersons who are also with us at the at the end of the session. And we are very much thankful to Inceptor Pharmaceuticals as well as United Hospital for their full support. And I am very much grateful and feel very much honored to be a participant of today's session. Special thanks to Planetaria Academy, and special thanks to Dr. Sharmin for the coordination. Thank you all. Thanks and good night to all.
Good night.
Thank you. Thank you, everyone.
Rehana, good night.
Good night.
আমরা দূর থেকে রেহানাকে পেয়েছি।
রেহানা কটা বাজে এখন?
এখন বাজে কয়টা বাজে? এখন বাজে হচ্ছে গিয়ে 6:30.
যাক, ভালো টাইম তোমাদের।
Okay, madam. Can we leave, Dr. Sharmin?
অনেক ধন্যবাদ সবাইকে।
Thank you, madam.
Thank you. Assalamu alaikum সবাইকে।
Good dream. Sweet dream.
Thank you, madam.
Assalamu alaikum, madam. Rehana, bye-bye.
Bye-bye. Assalamu alaikum.
Bye, Rehana.
Assalamu alaikum সবাইকে।
Assalamu alaikum. Assalamu alaikum. Sharmin, Joyasri, thank you.
Thank you, man.
Thank you, Sharmin. Bye.